Otherwise, I'll be on 24 hours a day. But email is my preferred way of answering your questions. Okay. Any final questions before we begin? Okay. So let's get started. Today, as I mentioned, is module 2, and welcome if you're a returning student or a new student. Glad to see you guys here. Keep doing it the right thing, and soon you will be a PMHNP board certified. Okay? So for all the modules, we have a roadmap, basically guides you what we'll be covering today. Today we'll be covering the MSE, the MMSE, which is different, right? A lot of people confuse those two topics. Um, Nurse therapeutic relations, suicide risk factors, substance abuse, some medications for alcohol use disorders. We're going to cover the cows, a lot of scales today, right? Seabird, delusion, neurocognitive disorders, which is a huge topic, right? And dementia as well. Remember that most of the questions will come from here, right? So what is the difference between MSE and the MMSE? Well, the MSE, think of it as your physical assessment, but for mental health, right? So everyone gets the MSE every single time, right? Whether it's my intake or my follow-up appointment. When we do the MSE, it's a way to judge how the client or patient mental health functioning, right? It offers insights and help guide the diagnosis and planning. So basically, it's collecting information as an MSE, right? As we call the patient to come in, we look how they are dressed, their appearance, their eye contact. The mood is what the patient says it is. How are you feeling today? Happy, sad, um, things are not going well, right? Whatever the patient says it is, at that point is internal, is how they feel. You cannot see their mood. However, you can see their affect. How do they look? Their expressions. Observe is congruent with the mood. Do they say they feel sad, but they're laughing and playing on their phone, right? Memory, testing like short-term memory, recalling words also belongs to the MSE, although more of a MMSE. So the MSE, we can also look at some some things like orientation, assess awareness, locations and situation, speech, the volume of the speech. Is it pressure speech? If ever you say pressure speech, you really are speaking to mania-like symptoms. Look at the insights and judgment, evaluating their understanding of decision making, knowledge, and consequence of not doing something, right? So when we say insight, it means how the person see the situation. How do you feel? How do you feel about your condition? That's their insight, right? I feel that I'm getting better. I feel that I understand that what major depressive disorder is, and that my medications, if I stop taking it, um, I may fall back into a depressive episode. Judgment would be something like this. If I drop a letter on the ground and the person that picks it up and is next to a mailbox, what would the person do? most likely the person will drop in the mailbox. It's next to the mailbox, got a stamp on it, right? Judgment would a normal person wouldn't just pick up the letter and completely break it apart or throw away or put it on fire, right? So that's the judgment. And the intellect in assessing the general cognitive abilities through vocabulary and problem solving. So that's in a nutshell your MSE. Everyone gets it every single time. Now, also something that you will see on your test as part of your MSE is this question. And that every single time we get one or two students that will get this confused. So pay attention because this one is super high yield and can almost promise you there will be on your test. Thought process is how the patient organize their thoughts and idea, not speech. Thought process is how they organize their thoughts and idea, not speech. For example, um, tangentiality and circumstantiality. When you think, if the test asks you, where would you document tangentiality? You'd say thought process. But what is tangentiality? Tangentiality is think of it as when you ask a question and the patient never answered the question, goes around, 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 and never, ever, ever answered the question. Circumstantiality is when you ask the question and the patient goes around and around and finally asks the question. For example, where did you go to high school? And the patient say, I lived in New York. My life was good. I play outside all day long. I really enjoy my high school time. I had a girlfriend named Mary, and I went to Piper High School in New York. Finally answered the question. So that's circumstantiality. Tangent, tangent, tangentiality is when the patient repeats the same thing but never says where he went to high school. Clear? So you need to know the thought process, what thought process is in detail, as you need to know thought content. It refers to the person's thoughts, how the person is thinking, and ideas. I am thinking of suicidality. I am thinking of homicidal ideations. I am thinking of delusions. It is likely that you get a questions on thought content. Very likely. Okay, so this is an easy topic that I am emphasizing so that you get this question right. I can almost remember like when I was in nursing school, this question on the test many, many years ago, right? Because I actually got it wrong. The question said, where would you document suicidality, right? I'm like, yeah, oh yeah, HPI, right? Like I'm asking how the patient's doing or how things are going, and the patient says, yeah, no, past 3 weeks I have been thinking of suicidality. Well, true, you still document on HPI because the HPI is why are you here now, right? What's different now than before? How long have you been having those symptoms? That's your HPI. But the true standardized way is thought content. For your suicidal ideations, you should put on thought content. For your homicidal ideation, you should put on the thought content part of your MSE. Now, if the question is the answer is MSE, you would be correct to pick MSE, right? If your answer is thought content, you would be correct. If your answer is thought process and it's about hallucinations, delusion, would be incorrect. Okay? Anyone confused about this? I know if you are, please say it because it's important that you get this point right if this question comes up. Okay? So thought content. Go ahead, please unmute yourself. I cannot see your screen. If you ask, I could not see. I think someone had a question or hands. No?
Yes, can you please um, give me more example on the thought process?
Yeah, so there are several examples on thought process, but think of it as how the person thoughts are organized, like a clang of salad, a salad clang, right? Where the ideas are connected. Echolila, for example, would be one. But the biggest one really is potentiality and circumstantiality. Like echolalia, it could be one of them. Word of salads, where things are mixed together, um, but doesn't quite make sense. Which is actually a good point because that could also seems like tangentiality, right? But it's not. But I really want you guys to know tangentiality, circumstantiality is the main high yield. We have tons of examples of thought process that we can use. But just think of how the thoughts and ideas are organized together in your head as the thought process. When you say thought content is what they thinking of, right? How they thinking is in one way that I kind of try to distinguish both. Has anyone has a different ways of memorizing this? I know there are several acronyms out there. Anyone has a better one or an easier one or perhaps a different one that works well for you? No? Okay. All right. Does it help you? This example that I gave you?
Yes.
All right. So let's move on. Okay. So now think of it of the obsessions and compulsion too, right? So intrusive thoughts and behaviors, uh, persistent thoughts and behaviors. So that is also part of the thought content. Okay. So this is a very likely to be on your test. Okay. Especially thought content and thought process. Very, very likely. Okay. Suicidal ideation and homicidal ideation also belongs to thought content, right? So, although simple, the MSE, a lot of people confuse it with the MMSE. Okay. So, hopefully, know that thought, suicidality, it could fall under the MSE, which document as the answer, as the possible answer, right? Tangentially, tangential thought could fall under the MSE, as it could fall into its thought content or thought process. Okay, so that way you're not tricked. Oh yeah, I thought it was thought content, and you're only looking for thought content in the answer, and then you see MSE, and you like gets thrown off by the answer. Okay, so now what is MMSE, right? Um, how is it different than the MSE, for example? Well, here let's talk about MSE, MMSE. First of all, if the question asks you another name for MMSE, It is called the Foston test. So right now you should put MMSE equals to Foston test. Okay. And then from this test alone, you'll be getting like 3 or 4 questions because it's very popular. Very, very popular. So let's see how it's break down. When do we say the Foston test or MMSE is a cognitive screen tool to identify and measure adults' status, competency, and status. Wait a minute. So the difference here is that over time, you can rely on this scale to assess the patient cognitive impairment over time. So, for example, dementia, you're doing an MMSE today, and then you do another one a year from now, and then you compare scores. So it's a very valuable scale, okay? Because it estimates the cognitive impairment severity and cognitive changes over time. And who do we use it? Dementia patient, Alzheimer's, right? It's an objective measurement to quantify adult competency, status, and impairment. Important. It's a cognitive measurement to be able to look a year from now and a year ago and see if the patient has decrease in their cognitive status or impairment. Okay, so the MMSE or Foston test, we looked at several domains like orientation, recognition, recall, attention, calculations, language, visual construct. Unlike other scales, high numbers are good, right? We don't want a high numbers on a GAD. We don't want a high numbers on a PHQ-9. Well, almost no other scale, not really. We have this LAM, we have a few others, but almost no other scales high numbers are good. On the Foston test, on the SLUM test, high numbers are good. Remember that, okay? So the maximum score is 30. If the maximum score is 30, if I score, I hope I score 30, that means I have no dimension, right? That means that I am good. Now, anywhere between 24 to 30, it's a normal score. If it gets in between 20 to 23, right? It's mild dimension. Below that, we start looking at the moderate and severe. So high score is good, 24 and up is normal. 20 to 23 is mild dimension. Could be considered impairment, not mild dementia. It's not as specific for dementia, but is a strong correlation. So one way that you can remember the Foston test is by saying oral with two R's, 23 RWD. If you care to remember all the components of the MMSC. Is it really important? No. But if you like in clinical and you want to remember the components of the MMSE or Foston test, you can remember oral 23 RWD. So the O stands for orientation, right? Orientation is date, time, and location. The R is to Recognition is repeating three objects. The second R is the recall. Recall is a test memory test that recalls three objects after 5 minutes delay. Okay. Now, I'll get back to you just a second here. Recall and registration. Recall and registration. It is likely to be on your test because students get this one confused all the time. Can someone explain to me the difference between recall and registration? Anybody can give it a shot?
Is it the duration of the time? For recall, it's after 5 minutes, and then registration would be immediate or up to 1 minute, right?
Perfect. Absolutely. Almost every week, I post this question, exactly the same question on Facebook. And almost every single week, we get over 50% of the students getting this question incorrect. Okay? So remember, recall 5 minutes. What is this? A cup, cell phone, and the box. I don't know. To put my glasses on, right? And then remember those three objects. After 5 minutes, I will ask you to say it. And then you do it. If I show the person the three objects, repeat it after me. Remember, I'll ask you again in a few seconds. And then at that time will be registrations, right? Registration. You are able to register the short-term information with a short amount of time. Recall, they are able to pick up the information within 5 minutes. So registration and recognition is recognition is being able to recognize it right away. Registration is being able to recall the information within 1 minute. Ability to recall new information learned. Very, very similar. But where people get tripped up is recall and registration, right? And remote memory is things that you should remember something about your childhood, events that are a long time ago, um, that you should remember last year or something like that. Fund of knowledge is the information that everyone should know. If I ask my 14 years old daughter who's the president, she should know, right? Well, yep. Let's leave it at that. Okay. So MMSE, false and test. We understand recognition. We understand recall, attention, and concentration. This one is very, very important. Okay. It is likely that you get this question as well. Every single test has it. Have you noticed? How do you questions that it'll probably be long, and then the core of the question will say something along how do you test for concentration? Or better yet, probably would give an example and ask which of the following domains of the MMSC it belongs to. If I say a series of seven, which of the following domain of the MMSC would this belong to? This would be attention and concentration calculation. If you spell the world backwards, where would it fall in the MMSC? So super high yield, recall, attention and concentration and calculation, registration, remote memory, and fund of knowledge. Okay, so a small slide that's super high yield that you should know in detail. All right. So frequently asked point is that some of these scales are in the public domain and some are not. So which one is not? Well, the MNC, it's not in the public domain. What does it mean? It means that it is not available in the public. You cannot just go there and give an MMSC to a patient, not the standardized one in a piece of paper, because that's part of someone's work, right? It's copyrighted. However, what can you do? Well, you can use the SLAM, which is a St. Louis University study examination. Guess what? Also, it starts with 30. 30 is good, right? High number is good. You can use the mini cog, okay? Write it down. Mini cog, put it equals to clock drawing test, okay? Equals to clock drawing test. Let me go back here. Something that I kind of did, I skipped because it wasn't highlighted. Language, right? Identify names of two objects and pencils, saying, hey, for the MMSE, car and pencil. Follow 3 steps command: reading, writing, and drawing. Drawing is part of the MMSE. So what are you going to draw? You're going to draw a clock. Draw a clock and put the names, the letters, I mean the numbers on it, right? So a clock drawing is part of the MMSE, but also it is evaluating which lobe when you do a clock drawing test or drawing a clock. Which lobe would you be evaluating there?
Right parietal.
The
Right,
right,
right hemisphere or right parietal.
right parietals. So what I want you to know is that the MMSE, there is a clock drawing test, but also in the mini cog, there is a clock drawing test. Okay. So back to the MMSE, you have to pay for. It's not in the public domain. Who is in the public domain? The MOCA, the Montreal Cognitive Assessment, the mini cog, St. Louis University Mental Health Stars examination. Mini cog also does the clock drawing test or drawing a clock. Okay. So hopefully this is very, very clear. Any questions here? All right. So could I have anyone could read this question for me, please? And the answer? Any volunteers?
I'll read it.
You're presented
Thank
with an
you.
80-year-old patient who was diagnosed with Alzheimer's disease 3 years ago and had an initial MMSE score of 27. Recently, the patient came to you with the MSE score of 26. As a medical professional, how would you proceed in diagnosing this individual? Number A, label them as severely demented. B, contact the doctor to discuss a potential misdiagnosis. C, reevaluate the Alzheimer's diagnosis. Or D, determine they have moderate dementia.
Okay. Which answer would you pick?
See,
C.
Okay. All right. So anybody disagree? All right, great. So from now on, if you haven't been doing this, consider using the static. Do not ever look at the answers, right? Always read the question and ask yourself, what is the question asking me? What is the core of the question? So the core of the question here, right, is the MMSC is 27 and recently came with you with a score of 26. So what is a score of 26, right? So that's what you should be looking at it. And then obviously you'd reevaluate the Alzheimer's diagnosis because it's because it is a normal, right? We will remember anywhere between 24 and 30 for the MMSE should be a normal score. Okay. All right. Um, Here we go. So can you identify which cognitive scale is not in the public domain? A, Montreal Cognitive Assessment, B, the Minicog, C, the St. Louis, Missouri, and D, the MMSC.
MMC.
C?
D.
D.
Okay.
D.
All right. Just want to make sure. All right. So the D is not in the public domain, meaning you have to pay for. Okay. All right. Consider scenario where a patient is asked to interpret a proverb. A person who lives in a glass house should not throw stones. Which aspect of this MSE is the nurse practitioner evaluating in these scales? Is this cognition abstract, attention, recall of information, or fund of knowledge?
Cognition.
Cognition.
Or abstract.
Oh, okay. Nobody thinks it's fund of knowledge or recall or attention?
Fund of knowledge.
Fond
Okay.
is not fond of knowledge
It's
because
not this is abstract.
abstract.
All right. Okay. So hold on a second. Hold on, guys. So what makes you think? What is your rationale for fund of knowledge?
Fond of knowledge is like asking a patient, oh, who is the president? Is like bundle of knowledge. Who is the
No.
president of the United States? You have to know who is the governor of so states. But cognition and abstract thinking out of the boxes. This is like a proverb. You have to have this cognition and abstract way of thinking before you can be able to answer this kind of question.
Okay. All right. So, but the person that the answer fund of knowledge.
I did. I think that makes sense now.
Okay. So thank you. Hey guys, check this out, right? We all learning, all of us, all the time. There is no such person that says, "Oh, I know all things at all times," right? It is very, very important. It's very, very important that you speak your mind here, and you get it wrong. Getting wrong is better than getting right, because when you get it wrong, it clears up your mind, and this is why we have the live classes, right? Because it's the same content, but it's always better when we hear from somebody in a different ways. So I thank you for actually coming out and speaking your mind. It's very important that we catch all these between my message and you receiving it, what could be misinterpreted. So it's very important. So thank you. Never feel wrong or ashamed from getting a question wrong. I'm actually very proud for when you get it wrong more than you get it right, because that way we can learn it together and dish it out what could be the mistake. Okay, so thank you. Yes, so when you say fund of knowledge, it is a true knowledge, popular knowledge that everyone should know. Now, who has problem with abstract thinking? What population?
Okay. Abstract
Schizophrenia.
is
Schizophrenia. It
schizophrenia.
is the core of the population. They cannot, the true schizophrenia, how should I say they cannot, right? That's
The autism group, right?
autism too. Yeah. But the core, especially on tests, is the lack of abstract thinking is the hallmark of schizophrenia. Very good. Very good. And by the way, that's high yield, what I just said, okay? So write it down. Lack of abstract thinking, schizophrenia. Okay, please write that down. All right, so I'm sure that by now you guys know that all your PDFs are located under the first video of each module. For example, video number 1, module 1, you have all your PDFs for module 1. Module 2, video number 1, you have all your PDFs for module 2. Someone today asked on our WhatsApp group, where is the PDF for the crash course review? It is located under the first video of the crash course review. Okay, guys, always email me. Okay, I look forward to answer your questions every single day. You know, I may not be able to answer right away, but I really take my time to give you a full answer. And if it doesn't work, if it does not work for you, still can't understand, tell me. Okay, so I'm here to really be by your side and help you get there. So I answer about 40 emails a day. So I do answer quite a bit of emails every single day about questions, misunderstanding, or confusions. That's what I'm here for, to really separate the kind of know to I really know this information. Okay. So now it's not surprising that we would have questions on therapeutic relationship, right? Because although we do a lot of things that psychiatry doctors do, we try to bring this extra thing to the table, which is the relationship portion, right? I always say that psychiatry, the field of psychiatry, are two things. One is knowledge and science, and the second one is hope. And we marry science and hope together, right? As we get the science from the medications and how things work and how people usually do better in one way, and we provide them hope. We can have the best professional out there. If they are rude, if they are yelling, if they don't show empathy, then nothing, the person receiving that knowledge is not going to feel good about it, right? So when we marry science and hope, that's what psychiatry is all about, right? So, and that's what we bring to the table as nursing. We have a different kind of way of talking and a different approach. Not to say that the medical doctors don't, which they do, but they are more objective, right? They're more science driven. We are more human driven in a sense, in comparison to doctors, right? So, importance of the therapeutic relationship, right, is about the patient needs and goals, right? So, it's what the patient thinks and wants. It's enhancing the patient care and well-being through effective communication, right? So, once again, when we think about nursing relationship, we want to think about the patient needs and goal oriented. It is different because if I see that the patient has major depressive disorder, and I don't ask the patient what do they want, and just say, here you go, take this medication, shove it, you know, take it, and that's it. It's not what the patient wants. Instead, is knowing what the patient really wants. And here are your options. These can work. We have these other options. This is less effective, but it could also work. Which one do you prefer? Where you are more comfortable with, right? So when we say the therapeutic relationship, right? It really is the definition of mutual, interactive, interpersonal relationship, myself and the patient, right? And we focus between the patient and the nurse. Focus on identifying patient's needs, right? It's a patient-centered approach of care. It's including the patient on the goals of the therapy and promoting patient's engagement and satisfaction, right? Rather than me saying your goal is to sleep 8 hours a day, I would say for someone with insomnia, what would be a good goal for you? In if we think that's approach of a CBTI, which is cognitive behavior therapy for insomnia, if this is successful, what would be your goal? Currently, you are sleeping 3 hours a day. What would be your goal? Rather than science approach or medical approach, your goal is to sleep 8 hours a day. Here I'm asking the patient, what would be their goals? Right? I know it takes time, right? But this is how it should be done. Right. Key concepts. In order to be a true therapeutic relationship, we have to engage few things. It has to be genuine, right? People know when things are fake. They just know. Genuine, being open, honest, transparent. It has to be an acceptance, right? Uh, Organizing each individual's unique experience, beliefs, culture, background. It has to be non-judgmental, right? Has to be non-judgmental, removing bias, prejudice, person's opinions from clinical interactions, right? For example, here, someone with substance use, right? Uh, Especially if they miss appointments, they don't pay, they don't take their medication, and they have substance use. So it can be kind of easy to not like the person or internally you knew that was coming to you. May never say this to the patient, but some of them is thinking because you're using drugs, you're not taking your medication, no wonder you're depressed, right? So we have to really check ourselves if this is our place, right? Because the moment you keep on falling to this road of being judgmental, you start to change yourself and you start to going into a different road why you decided to be a psychiatric nurse practitioner. So removing the bias and being able to let it go of the negativity and how you think things should be, and just being there for the patient at that moment. And believe me, this is probably very, very hard. But with time, you are able to almost have a body arm where you protect yourself, but you are also not passing on negativity to the other person because you think X, Y, and Z should be done in a certain way. You're there to serve, you're there to help, and not to judge. Okay? And you have to be authentic, right? Creating this trust by being genuine, honest, and maintaining professional boundaries, right? Empathy, right? Empathy is the most powerful thing ever. Being able to understand the patient's feelings and emotions without imposing personal beliefs or emotions. Empathy is being on somebody else's shoes, right? And oftentimes I say things like, I don't know what's like being raped, rather than saying being raped is hard. Well, I don't know that, right? Or something along those lines, like I don't know what's like being divorced or going through this problem because I haven't. But I can only imagine that you are going through a hard time, right? So that way you are authentic. I can't say that I know what's like being X, Y, and Z in their neighborhood, in their circumstance, if I have never been there? I can only say that I can imagine that's hard. Help me understand how hard it is for you, right? So I'm showing I'm being authentic because I'm not lying, but I'm also being empathy, showing empathy, trying to better understand the person's point of view, right? And the respect is very important. Keeping a clear boundary with respect, right? So these six things that we mentioned are part of the nursing therapeutic relationship, the core of what we do. Make no mistakes. You will have a questions on nurse therapy because this is unlikely to be in a medical board, right? Because they wouldn't necessarily be so focused on this. This is something special that we try to bring to the table on extra besides the science, right? Now, I almost guarantee you that you'll get a question on transfer and counter transfer because that is core. Who who coined the transfer counter transfer terminology? Anybody? Okay. Papalau, right? Papalau also mentioned the nurse therapeutic relationship. Now, if you think about this relationship, right, it's an exchange of ideas between you and the patient. And when we have this exchange, we have a transfer and counter transfer. A transfer is how somebody feels about me because the way I look. Hispanic, male, brown eyes, I don't know, a skin color. I remind of someone that did something bad to the patient or did something good. And that evokes a feelings on the patient that comes to me. So transfer is the patient's feelings and emotions towards the healthcare provider. Counter transfer, it's how I feel about the patient. Let's say, I'm just giving you a silly example. This woman, blonde hair, blue eyes, reminded me of my ex-girlfriend that cheated on me. And now I know it's not her, but she really reminds me of her. And every time I have this patient, I get angry and frustrated and feeling lost. So that is a counter transfer. Okay. So transfer is the patient displacing feelings of significant people of their past towards the healthcare provider. And this could be positive or negative. Countertransfer is the healthcare provider displacing their feelings and emotions towards the patient. Anybody surprised that you would have a questions on transfer and countertransfer? No, right? Because it's part of the nursing relationship of this core of therapeutic relationship. Now, a few classes ago, somebody said, think of the patient. This is a counter, nursing counter, and you are on the this side of the counter, and the patient is towards in front of you. When the patient transfer to you, is a transferring of the feelings. When you do counter transfer towards the patient, you towards the patient. I thought that was a pretty cool way of remembering and really keeping you in the counter. So it's counter, transfer, or transfer towards you. If that helps you, take it. If it doesn't, throw it away. Am I very, very clear on transfer and counter transfer? So again, therapeutic relationship is an exchange of information between the clinician and the client or patient, right? And we say that a good therapeutic relationship is a client-centered relationship of trust and respect, right? It's a collaborative, effective to promote physical and psychological well-being. Main points: transfer and counter-transfer, to remember. Anybody confused or need an extra explanation of transfer or counter-transfer? All right, so it has been just about an hour. So we'll be back at 6:05. So give you about an hour, 10 minutes, 5:54 now. So give you about 10 minutes break. I'm a big fan of break. Not that um I want to take a break. I really don't. I want to go all the way in, but I don't believe in overwhelming you. And I really believe that